Hello, everyone. Can everybody see the screens and hear my voice?
Yes, thank you.
Okay, great. Okay, this is the first of the series of webinars that our department organized, and I will be talking about the effect of Dobbs' decision on postpartum depression. And this is the paper that I've been working in last year. And it is, I think it's going to publish soon in Journal of Health Economics and Research. And also, there is a subsequent paper that's coming out on the same topic. And I will review those findings with you. So let me give you some background about the issue. First, as you know, the U.S. Supreme Court's 1973 ruling, Roe versus Wade, it rendered the authority to regulate and pass abortion-related healthcare law to federal government. And in June 24, 2022, the Supreme Court kind of overturned that ruling with its decision in Dobbs versus Jackson, basically returning regulating to the individual states on abortion. So after the Dobbs decision, it basically triggered significant changes in abortion laws across the United States. And 21 states basically poised to ban on severity restrict abortion access. And you can see that on the graph. And 14 states implemented near total bans. And 7 states, basically Arizona, Florida, Georgia, Nebraska, North Carolina, South Carolina, and Utah, they establish gestational limits on abortion ranging from 6 to 18 weeks. So when this happened, and we were looking at the effects, and because I will explain, this creates a great environment for a statistician to look at the effects on a Dobbs decision on abortion, because it creates a kind of natural experiment, and we start, collecting the data. And our motivation came from these two different ideas. That's basically, as you know, the abortion is basically termination of pregnancy, which can be done by 2 ways, either medication abortion or surgical abortion. But usually that arguments about the legal status of abortion focused on ethical, moral, or religious issues. But there was one aspect that was really interesting, that the effect on abortion, especially detrimental impacts on mental well-being. And basically supporters of the abortion access was saying that especially that implementation of the stringent abortion legislation at the state level, it amplifies the psychological distress experienced by women. And when confronted with the pregnancy, that kind of possesses significant health and financial risks. And the opponents of the abortion rights, basically, they were saying that, well, it is just the opposite, because the law can assist women in mitigating their pain or psychological discomfort associated with the pregnancies by preventing impulsive and irrevocable decisions that may lead to subsequent remorse. So actually in 2003, when there was a court decision on Gonzalez versus Carhart, Justice Anthony Kennedy stated that while we find no reliable data to measure this phenomenon, it seems unexceptionable to conclude some women come to regret their choices to abort the infant life they once created and sustained. Severe depression and loss of esteem can follow. So once we read this, basically, okay, why don't we provide some empirical data, whether it is true or not, and which one of these arguments could be supported by the data. And so basically, we said, let's look at the postpartum depression after the Dobbs decision. And in earlier studies, basically focused on the abortion trauma syndrome, which is basically women may suffer adverse psychiatric effects, including depression following an induced abortion. But there was a methodological challenges. And the main challenge was to create a control group to test this hypothesis. And because women who seek abortion after the gestational limits or carry unwanted pregnancies, they may be systematically different from the ones who actually get the abortion within the legal timeframes. And to control those differences with the data was difficult, because there was always this unobservable bias that you cannot collect from the data sets. And when the Dobbs decision happened, basically it provided a unique natural experiment to assess these effects. And because the state decisions to abortion rights can be considered largely independent of unobserved factors that are affecting the abortion demand. And so when we compare the states with restricted, unrestricted access, that kind of creates a novel approach to look at these decisions. So our purpose was basically add this empirical evidence on this hypothesis. And we use the Medicaid data set, but if you get the 100% Medicaid from the CMS, there are usually lags associated with it. And so in order to see the effect on Dobbs decision, which is done after June 21, 2002, one would wait for a couple of years to get that data set from the CMS. But there was another data set out there, which is called Kytera Lab, which covers almost 80% of the US patient population, and they get their information from clearinghouses. And so therefore they obtain some of the Medicaid population, some of the Medicare population, and commercial populations as well. So from the payer type, you can see that who is the Medicaid and who is Medicare, who's dual, and you can just get all these informations. So we said, well, 60% is a good sample. Let's analyze this and whether we can see that differences. And basically, we created two different samples, and one of them is the pre-Dobbs. From the figure, you can see that we looked at all the way to June 2022, from 2019 to 2022. We had this identification period where we identified the woman aged between 12 to 55 with pregnancies ending in live or stillbirth. Then we follow them, and we follow them if they had a postpartum depression. And we did the same thing with the post-Dobbs decision as well. So in the post-Dobbs, you can see that we look at the same group of patients, but they had pregnancies after the Dobbs decision, and we follow them if they had the postpartum depression. So the data has all these diagnosis codes, medication, procedures, some demographic values that I will go through. So it creates it gives us a wide range of variables that we can actually control for. And most importantly, that we were able to get the Medicaid data all the way to June 2024. And in our recent study, we actually expand that, and we went all the way to December 2024. So we create a design for difference and difference analysis. And for those of you who are not familiar with this statistical technique, I actually put a simple graph here. One is, so you can see that there is an intervention. Here is the intervention is Dobbs decision. So you can just consider this vertical line as a Dobbs decision. And then, of course, prior to Dobbs decision, there were some states. Let's say those are the pink states, and the other triggered ones, and non-triggered states are green ones. So there are postpartum depression. You can just think that as a y-axis, and of course there are differences between triggered and non-triggered states prior to Dobbs decision as well, and this method actually assumes that these differences is parallel to each other. But when the event happens, and that's the vertical line, and the ones in the triggered states is basically as a higher postpartum depression if one of the hypotheses is true, and it would actually, their slope would go up, and you would look at the intervention. And to get that intervention effect, you will look at the differences between triggered and non-triggered state prior to Dobbs decision. So that's one difference. And you can look at the differences after the Dobbs decision. That's the one difference after the event happened. And you can just take the difference of these two different differences. So that's why it is called difference in difference equations. And there are some assumptions behind that, which I will go through it. But basically, the idea is we want to see that if there's an upward slope, because upward slope means that postpartum depression actually increased after the Dobbs decision. And if it's a downward slope, that we will say there's a decrease. And the second, whether it is significant or not, whether that actually create a big impact. And third, if these differences are different for different demographic factors, like if some group of people that slope is different, let's say younger moms or people from the low socioeconomic status. So we look at the diversity as well. And so we have trigger versus non-trigger. There are 21 trigger states, 29 non-trigger states. We have pre-period and post-period. And the postpartum depression from the claims data set, since we don't have the clinical information, and we check the literature, and the validated approach is the following. So they said if the patient has at least one inpatient claim or one outpatient claim for postpartum depression diagnosis, which is F53, and or if they had one inpatient or two outpatient claims for major depressive disorder, because sometimes doctors code it as a major depressive disorder rather than postpartum depression, but they need to be at least 27 days apart from each other. And you follow them for the end of the pregnancy date and or during the third trimester of the pregnancy. And to distinguish postpartum depression from the other conditions, we eliminated any woman who had a history of mania or bipolar disorder during the study period. And also, to differentiate the new onset depressive illness in postpartum period from the ongoing episodes, we exclude anybody who had a major depressive disorder prior to last menstrual period from the study. So these are all new major depressive disorder patients right after the pregnancy, or postpartum depressions right after the pregnancy. And so that actually decreases our sample sizes, but it gives us a more homogeneous sample. And we had their age, we had their region where they were from, whether they're urban, rural area, and we have some socioeconomic status variables, which is zip code based, that is derived from the area deprivation index. And we collected some of the clinical variables from the literature. And we use commonly used indexes like Charlson Comorbidity Index, Alexander Comorbidity Index, chronic disease scores, which is based on the number of medication these women use, or if they have any obstetrical, maternal, or life risk factors. Again, these are all used the ICD-10 codes for identification. And we had also some state level variables. So we look at the unemployment rate in the state, the state's education level, or they have behavioral health provider density. Because social support is important for postpartum depression, we want to control for the differences in the states if they had a Medicaid expansion or substance abuse and mental health service administration, blood grants for mental illness. All of these affordable acts, if they were the part of the affordable act. So we have some statewide variables as well. So what we found from these two states, two different groups, you can see that since we have a larger identification time in the pre-Dobbs, we started with almost 1 million patients, and then we lost some of them when we put a continuous enrollment requirement and in the baseline and the follow-up. So we want to put a 1-year baseline continuous enrollment requirement because we want to measure their comorbidities. So before they're pregnant, how, what their Charlson comorbidity score was, what is their individual comorbidities, and all of those factors. And we want to, put continuous enrollment after, just to see that whether they had a postpartum depression. So of course, when you put those limitations, the sample size actually dropped from for both pre-Dobbs and the post-Dobbs. And so at the end, we had almost 179,112 women, and then 70% of them was pre-Dobbs, and 30% of them was post-Dobbs. And we actually look at the different postpartum depression rate. So you can see from this attrition table, for pre-Dobbs and the post-Dobbs, both in the postpartum depression diagnosis was around 10 to 12% on averages. And of course, PPD is underdiagnosed in health. Therefore, the actual diagnosis rate, clinical diagnosis rate, is a lot higher than that. And some people estimate it's around 25%. But usually you get almost half of it from the claims data set, and because most of them are undiagnosed. And so first we did the descriptive analysis. We compared these trigger and non-trigger states in terms of their differences in terms of their age, region, and all of these state-wide variables. And we use this difference and difference equation to see that if there is a differences in the postpartum depression rates. And we did some robustness checks. We actually matched these groups and to further remove the bias, because there are two types of biases that you deal with when you have difference and difference equations. One of them is, of course, selection across the groups. These people are different from in terms of demographic and clinical factors, and also there is a biases across the time. So the composition of the groups prior to Dobbs decision and after the Dobbs decision could be different, because some people can actually move from triggered states to non-triggered states, and it could change the total population. And Texas is a specific kind of state, because there was for those of you who don't know it, basically the Texas Senate Bill 8 was passed almost 10 months prior to Dobbs decision. Basically, they were effectively prohibiting the abortion beyond the 6 weeks of gestation. So the Texas is kind of unique states, and so we run the regressions with and without them, because Texas actually saw the states way before effects, way before the Dobbs decision happened. And so we had this, again, the models that we run. The here axis is the individual variables. For example, the patient's age, the woman's age, comorbid conditions. Z is the statewide variables, whether they have, Medicaid expansion, Affordable Act, and there are some state fixed effects for the factors that we don't control for. There's a time effect that we don't control for because we had like a COVID, as you know, we need to kind of control for those different years. But the key variable here is actually beta 1 that measures the differences here. And so basically, if we find a significant positive effect, we would say that there is the postpartum depression is increasing. And if you find a negative value, that means that actually postpartum depression decreased among the triggered states. So next, we looked at the numbers. So first, you can see that we have almost 100,000, more than 100,000 pre-Dobbs group of patients, 73,000 after the Dobbs decision. And after the Dobbs decision, between triggered and non-triggered states, they were evenly distributed. And prior to Dobbs decision, we had a little bit larger sample in the non-triggered states than the triggered states. So if you look at the differences, and I didn't put every variables here, but the one thing that you can notice that for the triggered states, they have relatively younger population. So we use standard differences rather than the p-values. And I'm sure that some of you are familiar with the p-values, because when you have a sample sizes that large, all of the p-values come significant because it is really depending on the sample sizes. So standardized differences basically removes that. So if you see anything that's greater than 0.2, that means that these differences are significant from each other when you look at the numbers. So you can see that basically for the comorbid conditions, they were pretty similar between triggered state and non-triggered states. But in the triggered states, the women were a little bit, almost a year younger. And of course, in the triggered states, they have their socioeconomic status was low. So they were more likely to live in the zip codes where they have the socioeconomic status level is low. And this socioeconomic status score comes from 6 different variables that people's the home values, if they have a job, and if they and some other variables that is related to socioeconomic status, their income and their education level. All of these 6 variables comes into the piece, and then it creates an index score. And from that index score, you can see that certain zip codes are high SES than the other ones. So in the triggered states where the law is actually triggered abortion restrictions, they're more likely to have in the low SES scores. And this is actually unemployment rate. So this is, as you can see that in the triggered states, they are more likely to have, when you compare to 31 versus 18, they were more likely to have a high unemployment rates. And in terms of the behavior providers per 1,000 residents, you can see that there is a very low behavioral healthcare providers for the triggered states when you compare to non-triggered states. Again, and they have a low grants and they have a low educational. So this is the one selection bias that I was talking. So these people who are living in triggered states are different from the ones that are living in the non-triggered states. And these trends were similar in the post-Dobbs decision too. So it is the composition of the group of people didn't change. And when we look at the variations, so you can see that after the Dobbs decision, and this is the postpartum depression, these variations actually became a lot larger, both and not as much in non-triggered states, but in triggered states, you can see that there's a huge variation in the postpartum depression, especially in the low SES group. So when the people who are living in the zip codes that has a low socioeconomic status, you could see that the depression rates were varying a lot. And that variation was not as big when you have middle SES scores or in the high. And we look at the, these are the triggered states, for example. And if you look at the post and postpartum depression rates, for example, you can see the notable differences here in North Carolina that jumped from 5.8% of the people who had a postpartum depression. That ratio went to 16.7%. Again, Kentucky, you can see that 16.8% jumped to 25%. Again, that Wyoming, that you have these huge jumps. And so for individual states, you could see that differences, and there are some states that it just went opposite direction, and there are some explanations for that. At the end, I will talk about that. So first, we test the parallel trend assumption. So this is an important assumption. So basically, it is saying that if there was no Dobbs decision, the trend would be similar. So we compare the percentages in the different time periods, and you can see that the differences were actually the same. So the parallel assumption was holding. It is very difficult to test because you are trying to test something. It's kind of counterfactual. So you are saying that if Dobbs decision didn't happen, you would keep the same trend between triggered and non-triggered states, but it happened. So the way to test this, you would actually go back and see that, let's divide the pre-period in several parts and see that if there are differences in the factors. So once we test these assumptions, and we run like 3 different models. And so first one, we said, let's not put any variables in it and just look at the rates between pre and post. And this is basically showing that there is no difference in the postpartum depression. And you can see that when we didn't put any variables, and when we didn't control the differences in the women who are pregnant, different states, and there was no significant effect. And when we put the covariates, we found the positive differences, but it was insignificant. So there was a wide variation, and there was a positive effect, but insignificant. And when we do the propensity score matching and do the covariates, we were still seeing some kind of positive effects. And this could be like most advanced. Basically, we are matching the people who are in the triggered and non-triggered states, and then we are running the difference equations. So basically, double controlling the factors that are different. And so the main conclusion, overall conclusion, was saying that, okay, we are seeing some positive effect, but it is not significant. So neither of these arguments could be supported in the empirically. And we look at the different groups. Let's look at the younger mothers. If they were 25s and below, and then would we see some differences? Again, we were seeing a positive effect, but the variation is so wide that we couldn't actually find big differences. And then we said, okay, let's look at the different socioeconomic status. So that triggered our second paper, basically. When we look at the socioeconomic status, when we saw that when women who are pregnant, they were living in the low SES zip codes. And we were finding a really big, positive, significant effect. And we said, okay, let's redesign the entire study and just capture the only ones who are in the low SES scores. So basically, rather than having 179,000 patients, let's look at only the ones who are living in the low SES areas. And by that time, we had a new data set. So we extended our end period from June 2024 to all the way to December 2024. So then we rerun everything. then we saw that, for especially for the low STS groups, and it doesn't matter what model we run, and we were always seeing a positive effect, positive and significant effect. So that was basically indicating a disproportionate burden in socioeconomically vulnerable groups, that they were having a positive effect. And we run the model with Texas, without Texas, it doesn't matter. We were always finding a positive effect. And we did the same similar assumptions, parallel assumptions here. And so then we were looking at the literature, that how come we were getting a null effect for overall population, and we find several interesting articles on that. One is about the abortion trauma syndrome, basically, that basically the distance to nearest, many women may kind of still access the abortion through the out-of-state travel. And we looked at that in the literature. Although that differences increased, before the Dobbs decision, the women usually had to travel 43 miles on average to the clinic, abortion clinic. But after the Dobbs decision, on average, they had to drive 330 miles one way to actually get the abortion clinics. And one study showed that 75% of the pregnant residents, actually they are seeking access from the banned states, will travel to facilities in state without such ban. So basically, from the surveys, they would actually saying that you could actually travel that. And there was also a rise in demand programs like Aid Access, which is a nonprofit organization that provides mail order access to medication abortion, and via overseas pharmacies, that actually confirms that individuals unable to manage the logistics and cost of traveling, they were going through the self-managed abortion without significant health risk. And there are also kind of enhanced access to comprehensive range of contraceptive methods, including long-acting reversible contraceptives, kind of may contribute to reduction in the unintended pregnancies. So the effect of the Dobbs decision actually mitigated because of those factors. And so that was one factor. But also some people that that the rates are small, but if you actually turn into the numbers, even if 0.003% increase, that means that there is 1,400 additional postpartum diagnoses annually. So that is especially this, each case represents a significant distress and impairment effect for the mother, and that has a potential impact on infant development and family functioning. And most of the postpartum depression actually turn into major depressive disorder in upcoming years. So that's an effect. And you saw that low STS group experiences significantly higher effects, and that basically highlights the importance of other kind of addressing disparities in mental health outcomes. And so there is a kind of, in terms of policy and health implications, there's the acuity concerns, and the low STS women face greater barriers to abortion access, especially their costing to travel the nearest abortion clinics. And there's jobs insecurity, and there's a physician shortages. So that's another thing. Basically, the physicians, the Medical Association of American Medical College reports that there's 5.2% decrease in obstetric or gynecology residency application in states where abortion bans, when you compare to the states when there's no abortion bans. So there is physician shortages, and that will kind of amplify the effect of depression. And of course, there's a potential rise in the infant mortality. One study showed that there's a 12.7% increase in the infant deaths in Texas over the comparison states. So there is that application. And so that therefore the policy implications that we can suggest that we should have Medicaid expansion for postpartum care. There is a new medication that's approved for postpartum depression, but some states has if you're an open access policy in the Medicaid, you could have an easy access, but some of the states they don't have that, and that medication is actually used for only 14 days, and it is very effective, and it is recently approved, and the states may want to make sure that they have this access. And of course, community level social support infrastructure is important, especially for the states who are triggered for this law. And so I have one couple more slides, and then I will, if you have any questions, we can discuss. Of course, there are some limitations, and it is only for Medicaid population, and Medicaid has only around 40% of the U.S. births. So, and this could be kind of expected commercial claims. And we didn't have the race data, unfortunately, so that the race is an important factor. And also we don't observe the cross-state abortion travels or unreported self-managed abortions. We don't have that variable, and which has definitely effect on our conclusion. And this is a clinical diagnosis of postpartum depression. It is not a postpartum depression. Again, this is the postpartum depression is underestimated in the healthcare claims, and we're only looking for the shorter time after the Dobbs decision. Maybe these effects will either be more and more over the years, or it will be mitigated by easy access through the medications, etc. And so that was the kind of summary of the papers that I'm working. And so there is so in terms of the conclusion, I can say that there is a positive effect, and especially in the low SES scores, and it is significant. And finding support policies targeting postpartum mental health, especially for the socioeconomically disadvantaged groups, are important. And of course, if you could expand the study with the include the race and ethnicity effects, or kind of validate these diagnosis codes with the clinical traits, that would be also very, very effective. So these are my slides. Thank you for listening. I think we have, I don't know how many people, but okay, we have 29 people, and I'm going to open the chat to see if there are any questions. Okay, Nassim, you asked something. I mean, you can just let me.
I think it's maybe Mustafa, or so. I think some people joined with my Zoom. Mustafa, that's you, right?
Okay, yeah.
Hi,
Oh.
Onur. That's really great. Thank you very much for sharing your work with us. I was just wondering if you've done any sort of balance tests to see if the state characteristics, the differential between state characteristics, states that are trigger versus non-trigger states, around the time of Dobbs adoption. So Dobbs was also during the pandemic, or during sort of the the trouble, the upheavals of the pandemic. So perhaps there's some role there to some of the things you see. It might have induced differential shocks. The pandemic might have induced differential shocks for states that are trigger states versus non-trigger states, in which case the parallel trends assumption in the post-Dobbs time would not be satisfied. And so the estimates might be a little off. So I was wondering just if you've done any balance tests, whether, for example, some of
So basically we did postpartum a propensity score matching between the individuals and the states, and when we run the difference and difference equations, we use the fixed effects for the states and the time, which doesn't capture all these intermediate shocks that you mentioned, but we didn't do separate things like I suggest. That could be a good addition.
Sounds
Oh,
good.
Onur, this so great to learn more about this research. I know you gave me the headlines before, but this is the first time kind of, seeing what's under the hood. So really great work. Couple of questions. One is, what was the definition for low SES since your entire population is Medicaid? And then second, um, given that there was quite a bit of interstate variability among the trigger states, did you take a closer look at, what might be driving those different patterns, between the states that showed an increase in your outcome versus states that showed no change or a decrease?
Yeah, so for SES scores, we actually created this index value by using the census variables, zip codes, and the 6 different variables. And we actually ranked them. That's basically the bottom 30% versus top 30%. You can just think that it was empirically determined.
Got it.
And
Okay.
yeah, and so uh, for the graph, this one, we did the similar one with the non-trigger states as well. We didn't actually look at the individual differences. Again, that if we had, if Kentucky is really away from, like if the adjunct state is also triggered, so that would be increase the driving distance to the nearest abortion clinic. That would increase the, for example, postpartum depression rates, etc. And for example, that would give you the highest rate before, pre, and post. But the variation that we don't look at the individual ones.
I'm just wondering, is it mostly SCS because Kentucky, West Virginia, maybe even poorer than, some of the other states, or is it something else? Or, like, for example, the ability of women in those states to access via other means, access care, via other means, maybe
Yes.
limited in some states, some trigger states versus others. Yeah.
Yeah, so that's a very good point, because when we actually create subgroup analysis with only low SES scores, and when we find
Yeah.
significant differences, I am assuming that there are more proportions coming from these states than the other ones, for example, Tennessee. And therefore that kind of triggers the
Yeah. North Carolina is interesting, right? Because I don't know what's going on there, because that seems like a big jump too, but
right.
okay. Anyway, that's just really, really, yeah, it's more food for
Right,
research. You have some other folks with questions, I think. Doralee, you have your hand up.
Yes, hi, good afternoon. Thank you so much for presenting this research. This is really interesting. So looking here, I was also, to piggyback off what Terry was saying, I was also looking at, the states where you're most likely to have like really rural populations, places like North Dakota. Whereas like it's quite interesting that like North Dakota and South Dakota have like the opposite situation going on, even though both are quite rural places. And I know the access to healthcare providers is difficult in those places. So I was curious what role geography had to play here, or if that would be like an area for further research.
Yeah, I think yes. I mean, we didn't want to lose ourselves by looking at every individual states. But again, yeah, that's another good point. I'm not sure what's the difference, because they're very close to each other,
Yeah.
and right, and it is
And it's
not
like almost exactly the opposite. It goes from 9.6 to 16.5, which is what I expected. And then with South Dakota, I expected something similar, and it's the complete opposite from 16 to 5.6. But I don't know if maybe the people in South Dakota have access to other states, whereas like, if you're driving, you have to drive through South Dakota to get to another state, all right? Or you'd have to try to go to Canada. But I don't know how feasible that would be. So that was just something that stuck out to me.
Yes. I
You
will
know,
take a look into this.
yeah, I wonder, so does your analysis take into account Medicaid expansion and when that happened in different states? Because
Yes.
South Dakota, yeah.
But these are descriptive variables again. Yeah, maybe that could be one effect.
South Dakota was one of the later states. I think it only expanded Medicaid in 2022. So does that create a slightly different population, post-Dobbs in South Dakota compared to pre-Dobbs?
Are you
So these are
considering?
these are not rate adjusted. Go ahead.
I was gonna say, aren't you limiting the sample to only those with continuous enrollment over the years post or pre?
Yes.
Right.
Oh,
So the
so that it would
populations wouldn't
exclude
change.
anybody who
Yeah,
got enrolled because of the expansion.
potentially. Yeah.
Yeah,
Yeah.
right.
I think
That's-
Diana has her hand up.
Yes, Diana.
Hi, thank you. Actually, Terry, your question was part of what I was curious about as well. The expansion of Medicaid for pregnancy, not only is time a factor, right? When expansion occurred, and certainly from the historic 6 weeks postpartum to a year postpartum, but also states determine the income level, right? Cut points. So it seems that there's wide variation across states in terms of the amount above FPL that people would qualify. So I guess even being in a state, notwithstanding Medicaid expansion in pregnancy, there's still a lot of variation in terms of depending on what state one is in as to whether they're actually eligible for it, not based on that income cutoff. So I guess on the one hand, maybe what Mustafa said is like everyone is eligible, right? Because this is a Medicaid only population, but what makes them eligible vis-a-vis their income level is different, right? So I'm just wondering, maybe Onur, you already answered this to one of the previous questions, but is that taken into account? Because and how so? If you could just explain a bit.
Yes. So this is basically these rates are from descriptive. Of course, these are not adjusted, but in the model that we have this, the state fixed effect. Basically, this control for the differences among the states, which we don't have as a variable here. So that's one of the assumptions. And if there are differences in the states where they have a different access and all and different timing, you are assuming that this assumption is going to control. So at the end, when we give you the coefficient and whether it is significant or not, all of those differences are going to be controlled, and as much as you can with the variables that you have. But that differences can trigger the variation that you see here because these are not adjusted.
Okay.
Yeah.
And then just, I guess maybe a more sort of, this is on the recommendation side of things. Among those that you listed was, I think, Medicaid expansion, right? But at the end of the day, your comparison is pre and post Dobbs. And so that key variable is the trigger, the automatic ban on abortion. So this may be incredibly ambitious and ideological, but I would imagine that one of the recommendations should be advocacy to remove the ban, right? To actually, and I see Terry smile, it's like, clearly states had those trigger laws in there for a reason. But if we have data to show that, at least under you indicated the lower SES component of the sample, that there was a significant increase or difference in the experience of postpartum depression post-Dobbs. That to me supports an additional recommendation that the ban or the restrictions on abortion care be reconsidered or at least lessened with regard to, even if it's in the context of mental health outcomes. Did you think of including that recommendation?
At the end, I see.
It wasn't on your list, is I guess what
I see.
my
Okay.
attention.
I see. So this
Yeah, the
is
policy, right.
right. So as you said, it could be too ambitious, maybe.
Well, no, some people may think it's too ambitious, but I think it seems like you have evidence to support that, at least for the low SES population in this Medicaid population, that there seems to be an impact of Dobbs on the experience with postpartum depression, right? If I've captured that correctly, and that's the variable, it's pre versus post Dobbs. It seems like a policy response should include a lessening, if you will, of the restrictions around abortion care.
Right. So that could be maybe, rather than having a totally restrictive ban, it could be at least, if you want to put something, you could put 12 weeks to 8 weeks to 18 weeks as some of the less restrictive ones, at least for the ones. Yeah, we can definitely add that.
Right.
I'd be careful, like kind of prescribing how many weeks, because you're not,
Yes,
because your research doesn't really get at that so much. But I do think that it might be worthwhile to take a look at, some other health outcomes, because I think that if you look at other health outcomes, as a cluster, maybe there's, a more substantial argument, that you could potentially draw from. And I think this next step in terms of looking at the variations across the trigger states, that might also shed some light on why, we're seeing such big differences, in the increase or no change or decrease in PPD across those states. One of the things I worry about is people will say, oh, look, there is no overall effect. And actually lots of states, didn't show worsening PPD, right? They might actually use the finer pieces of your findings to support their, the continued ban on abortion. So I think that's something that, we may want to preempt by looking at, further evidence, why that might be the erroneous conclusion to make.
Yeah. So I was actually surprised that I was expecting bigger difference. Like you said, it is, and when everything come out insignificant, that was pretty much, I was surprised of that. Then I find out, this aid access, how popular they are, and how people actually get this mail order access, and how people actually willing to travel to the other states, although it is some longer distance now. That kind of justified a little bit.
Right. So even if you're able to show that in the states that didn't show an increase in PPD, that those are the states where, many more women had access via other means, that would essentially help mitigate this erroneous conclusion that people might draw, from your data. You see what I mean?
Yeah. Right.
Liz and I think I saw somebody else. Andrew, Liz, you can go first.
Yeah, Terry and Diana are onto some important points, I think, Onur. And one of the things is this is really nice data looking at the incidence of PPD. But if you can also aggregate other adverse health effects, and you have the advantage of being an economist, and one of the best arguments in terms of changing policy, like Diana talked about, and saying, okay, maybe the solution is no ban, is putting hard economic data. So you've shown in certain jurisdictions that there is an expansion of PPD and diagnostics. There's a corollary expansion of costs associated with that. And one of the things that can be very, very effective in terms of changing policies, if you show not just that there's been an impact, people sort of care about health impacts, but when you talk about the dollars and cents it goes to the state and how much this change in law is impacting the public coffers in the states, that's where people and policymakers start looking at it a little bit more objectively and saying, okay, we've got all these other issues going on and it's a lot of health and a lot of people believe that there should be access and expanded access. And oh, by the way, it's also causing, X millions or billions of dollars in addition on top of it. And that's very often a very, very effective policymaker argument in terms of completely overruling or changing laws. So I would, take it, if you think about it, taking it one step further, taking Terry's advice and sort of adding other health impacts, but also aggregating the costs of those impacts can be really, really strong and powerful.
Yeah, that's a very good
Yeah.
point. That, basically, healthcare resource utilization and the cost, the emergency room access and the cost associated with it. That could be another thing. Yes.
And the corollary to that, when you're talking about those costs, and particularly things like emergency room access, what people don't understand, it's not just that it costs more, which it does, but it also blocks access, right? So for every emergency department bed that's filled by a postpartum patient who otherwise might not, there's a cardiac care patient that isn't being necessarily treated if that bed's already occupied. And so the pressure on the resources and the limited access of resources for other patients who want to utilize that sources is an argument as well. And that can go back, by the way, just to unwanted pregnancies, right? So it's a lot more expensive just to talk, get the morality of all this stuff out. It's a lot more expensive for a woman who does not want a pregnancy for whatever reason, health or economic or whatever, to give birth than it is to have an abortion. The procedures cost more in terms of what's going on. And so, looking at, we've got limited access to healthcare. This is the portion of healthcare that's now going to this because of these changes in law. And that limits access to other people who, whether they be cardiac patients or cancer patients or other different types of things.
Yeah, absolutely.
So
And yeah, go ahead.
there was someone else.
Oh, Andrew, I think had a question. I would just want to see if he still had his question with his.
Yeah, I put it in the chat. I was just going to point out that some of the states that you're considering, like South Dakota versus North Dakota, South Dakota had a referendum and voted down the protections. And I'm wondering if maybe political activity, although that's developed later, I'm wondering if political activity might have had some role in this.
Yeah, good point.
Yeah, so Onur, I think you have several years before Dobbs, right? And you have several years after. And so one of the most flexible ways to run this diff and diff is to do, if you go to your parallel trends figure, like the actual one you showed, the real one,
The figure, this one?
the real one, the one with your data that you test the parallel trends assumption.
Oh, I see.
Yeah.
I
Yeah, keep going. I think, yep,
This one.
maybe. Oh, this one. Yeah. So, so since you have several years of data before, even months, I mean,
Mhm.
you can observe the months of diagnosis, of visits, and so on, or quarters before and after the policy. You can completely disentangle any heterogeneity in the timing of policy effects or dynamic policy effects in the post period. You can also test parallel trends and anticipation and a whole bunch of, you run sort of causality tests and the pre-trends on the pre-trends. But you would go beyond this simple, post minus pre in triggered versus non-triggered states to just a full set of periods and groups. And I think that would allow you to also see whether trigger laws start differentially across certain states but not others, whether the pandemic introduces certain things or contaminates the way that these effects show up. And then you might not be able to see effects in the early years immediately after Dobbs or the early quarters immediately after Dobbs, but you could potentially pick up sort of more distant effects as states actually start to enforce these laws and cause, additional cases of postpartum depression and, mental health issues to rise as they continue to crack down on abortions afterwards.
Yeah, you're right. So since I have the continuous, I can just right now I cut off 3 months, but I can
Yeah.
actually keep doing it after that too. That's a good point, Ahmet. Okay.
Any other questions? So I think this was a great kickoff session for our new HPAM headline series. And we have another one coming up that's going to be presented by Thomas. So I welcome all of you to register for that session as well, if you haven't done so already. And I think this will become a new thing led by HPAM, and we'll continue to host these regular research highlight sessions as we move forward. So please do stay tuned. All right, Onur, is there anything you want to say to close?
No, I mean, I want to thank everybody to attending this and giving me a great feedback. I really appreciate your time, and I'll thank you.
We can send around the papers that have been published as well, because the
Good.
first one was already published, right, Onur?
Right.
Yeah, the low SES one, is it out yet, or is it?
No, it's not out yet.
That's not out yet. Okay, so we can have Alicia share with the attendees the paper that's been published already, and we can follow up with the low SES paper when that's out.
Okay, great. Thank you.
Fantastic. Thanks, everybody.